And for the last 50 years, when the first spinal cord stimulation was done in 1967, so those are based on a gate control theory. Even today, this theory stands good. Most of the devices, especially the ones which are paresthesia based, they are utilizing this theory till date. And this was the theory which opened the gates for us, for the companies to develop all kind of softwares, hardwares, in terms of the spinal cord stimulator. So in spinal the main thing is the lead, which goes into the epidural space, the posterior epidural space. It can be a cylindrical lead or a pedal lead. What we are doing as a pain physician, we are usually using the cylindrical leads because this can easily go through a epidural needle. This pedal lead, they are used by the surgeons because that needs a laminotomy, and you have to do the procedure usually under general anesthesia. It's quite painful. And the site where ultimately this lead will go will depend what indication you are doing. It can stay in the cervical areas or in the thoracic areas, whether cervical for the upper limb neck pains, and the thoracic for back and low leg pain. So indication by most common is the PSPS type 1 and 2. The CRPS, although nowadays people are doing more of the DRGs for the CRPS rather than spinal cord stimulator, because the DRGs, they are giving good results and they are precise location we can put for a particular nerve, you can put the DRG at that level only. Any kind of neuropathic pains, whether peripheral, otherwise, people are using the spinal cord stimulator, especially the high frequency ones for the visceral and abdominal pains and intractable angina patients. So we have divided the spinal cord stimulator in two categories. The one which are paresthesia based or the traditional ones, and that's the only thing available in India till date. The other one are the novel or the paresthesia free. It can be the burst, high frequency, DRG, and lastly the ECAPs, evoke compound action potential ones. So on what parameter basically these stimulators are working? So whatever way you are programming the IPG, that will deliver something what we call a charge dose. So this charge dose has got a component of frequency, a pulse width, and amplitude. So these are the main parameters in all kind of spinal cord stimulator in different combinations. So frequency can be from the 40 Hz to 10,000 Hz. The pulse width for how long we are giving the current per dose. And the amplitude is how much amount of the current we are giving. So in response to this neural stimulation, the nerve may respond in the terms of there may not be any response, or can be a suboptimal, and it can generate an action potential. So that will depend while we program the patient, and the patient will tell where I am getting good pain relief now. And this whole thing, it depends how far is your spinal cord from the lead, whether the tissue is migrated or not, and how much is the thickness of the fiber. Other most important thing is, once you are stimulated, given the stimulation to the lead, how this stimulation is dying down. These are the repolarization waves are equally important for spinal cord stimulators. They can be active repolarization, passive, it can be symmetrical or asymmetrical. These strategies are very important so that there is no accumulation of charge on the lead. Because that will ultimately heat up the lead and may damage the neural tissue. So this has to be decided. Usually most of the spinal cord stimulator we are using the passive recharging with a symmetrical waveform. So this is the preferred one. So tonic one, which is being used for last 50 years, based on the gate control theory, was done by Shelley in 1967. It is based on a frequency of around 40 to 120 Hz with amplitude of 3.6 to 10 milliampere and pulse wave of 300 to 600 microseconds. This all you can program in the programmer. And this is basically giving a continuous current, and the patient will feel the paresthesias, which usually we have to map. That's this paresthesia are happening in the same place where the patient got the pain. The mechanism by is working on the spinal as well as on the supraspinal levels. As spinal levels is stimulating the A beta fibers, which in turn stimulate interneurons, and these interneurons by secretion of the GABA they are blocking the inputs coming from the A delta and C fibers. So basically they're closing the gate for the incoming information. And on supraspinal, they are working on the medulla levels where they are stimulating the descending antinociceptive fibers. So at spinal, supraspinal levels, they're basically trying to modulate the pain cycle. So limitations of this tonic one, and this, mind you, this is the only thing available with us in India. There's a problem of overstimulation. Suppose you cuff, IPG is delivering the same current at the same rate and with same amplitude. With cuffing, what happens? Your spinal cord comes in contact with your lead. The distance reduces. That time the patient will get a shock kind of thing. The patient is doing exercises, he bends because the current is going at the same duration and amplitude, he'll get a shock kind of thing. That's what we call an overstimulation. And otherwise also, these conventional stimulators, they are not giving good results for patients for whatever indication we are using. Around 60-70% is the pain relief. That too happens in around 50% of patients. That's why our patients are coming to us every other day. I'm not getting this good coverage. And then certain area we are not able to cover, especially the toes and pain, groin pains. And with long-term study, we have found out that these conventional stimulators, the effects keep on decreasing. We don't know what is the reason, but with time, even if you are using, now the Medtronics have come up with the DTM technology, they have even introduced the ECAP also with the same thing, but the results have not improved. That's why our patients in India are not happy with the spinal cord stimulators, and we are also struggling with the pain management. So over the last 50 years, things have changed altogether. We have now IPGs which are much smaller size. Earlier we used to put the IPG in the abdomen, and now we can put on the buttocks, even on the paraspinal region. They are so small. The leads are very steerable. You put in the abdominal space because it takes a lot of time to place the leads at certain position. So they need to be steerable. So you can control from outside. Now we have the wireless technologies available. Devices are becoming more and more MRI compatible. You can do MRI on 3 Tesla. Earlier, there were limitations not going beyond 1.5 Tesla, but now you can do it on 3 Tesla as well. And we have more and more good stimulation parameters available, which is almost minimize the paresthesia. Because although we say that paresthesia should cover your painful areas, but sometimes even the paresthesia are so painful, it's worse than your original pain. So that thing has probably gone away. The first among the non-paresthesia based is the burst stimulation. So here they are working on the baseline of 40 Hertz. In between this baseline, there is a burst of pulses at 500 Hertz, 5 pulses of 500 Hertz in between the baseline. So Ritter is the one who has done a lot of work on the burst stimulation, and he's saying this is something near normal, what the normally nerves behave. So another important thing about the burst stimulation is they are working with the DWR, the wide dynamic range neurons. They are not working on the A beta fiber. Altogether new target, and they are stimulating the medial lateral spinal thalamic tracts. So lateral spinal thalamic smack is for the pain, but the medial one, it takes care about the other component of pain, the affective emotional components. So that way it's covering the whole idea of the pain. Other is the high frequency one. These are around 10,000 Hertz with 30 microsecond pulse wave. So the last one, the closed loop, I was talking about the overstimulation. This is something which is sensing each stimulation going to the spinal cord. Every stimulation will calculate the distance of spinal cord to the leads. Every time the stimulation given, it will calculate the time. So you will get all stimulation at different parameters, so that patient doesn't get any. I have not even completed half of it. So technique-wise, you have to go paraspinal. Your spinal, when you go in the abdominal space, the needle should be this much shallow. Usually we give the abdomen like this. It has to be very shallow, around 10 to 15 degrees to the spine, so that your lead is going absolutely straight. You have to start on the para, medium, 2-3 segments below, and you need lead needs to stay in the midline. Complication were around 50% of the patient, they have some kind of the complication. And the most important are lead migration and lead breakage and infection.
We are, I think, running out of time. We are running out of time.
I know.
Already.
Let's stop it.
Yeah.
Okay.
So we'll take it in the question answer, I think.
Just to say, anchors and strain relief loops are very important. When you put the lead, when you put the anchor, that anchor has to go beyond the fascia. So that will eliminate the problem of lead migration as well as lead breakage. And then once you put the anchor, after that you have to put a strain relief loop. So you are giving extra amount of the wire for your different postures. Suppose you bend, you run, whatever you do, so there has to be some leeway for the movement of the leads. So infection wise, now there is a protocol of MRSA screening for the physician as well as for the patient, because it's around 30,000 pound device. You cannot throw it like that. You have to be very careful. OR traffic should be minimum. You have to do it in a meticulous way. You have antibiotics. You have to change the gloves when you are handling the IPG. You have to, now there is a concept of single stage, because we are usually doing a
Dr. Raj, I think
okay, sir.
Talk for the next session, it will be started.
Now people are doing it in a single stage. They are no more doing a trials, so that there is